or monthly pituitary. Okay, so I'll start the speech again. This is our monthly pituitary session. It's always a pleasure, and we have here Dr. Sampson, who leads our pituitary endocrinology program, and also we got our fellows today. So it's going to be a nice day with two interesting cases to discuss with the team. So Dr. Navajo, please go ahead.
Thank you, JP. Can you see my screen?
Yeah.
Perfect. So good morning, everyone, and welcome to our case records of Mayo Clinic, Florida. This is JP Navarro, and I'll be presenting the first case of today. So first, I would like to, I would like to acknowledge the whole team involved in the care of this patient: Dr. Chaichana, Dr. Almeida, Dr. Donaldson, Dr. Chang, Dr. Eggenberger, Dr. Alvarez, Dr. McKenna, Dr. Gentov, Dr. Gupta, and Dr. DeVias. Thank you all. Well, we will start with this 59-year-old male who has been followed up by rheumatology and endocrinology in an outside center for previous diagnosis of Paget's disease of bone. On February 27 this year, and in endocrinological workup, the patient showed abnormal levels of testosterone and prolactin. For this reason, on March this year, the patient underwent an MRI that showed a heterogeneous enhancing cellular mass measuring 3 centimeters. For this reason, the patient was sent and referred to us here at Mayo Clinic, Florida for evaluation and management. At presentation, the patient was completely asymptomatic and as part of his past medical history, as I previously mentioned, he was diagnosed with Paget's disease of bone. He was obese, had hyperlipidemia, kidney stones, and age-related nuclear bilateral cataracts. Physical examination, nothing remarkable, just slightly increased blood pressure measurements with measures of 136/83 and a body mass index, as I previously mentioned, obese patient with BMI of 30.34. In the physical examination, neurologically intact and nothing abnormal here. In his initial lab work, I don't know if Dr. McKenna, would you like to comment on this?
Sure. As you mentioned, the prolactin had been found to be elevated. Per outside notes, it seems like the prolactin had actually been elevated as high as 243. That was per the patient. But in our labs, it was found to still be elevated. Additionally, he was found to have low testosterone at that point in the time of these labs. He was not on any testosterone to our knowledge, which is also further supported by the fact that FSH and LH were within more normal limits rather than being suppressed. The other thing to point out with these labs is that the cortisol, although it's listed as normal, it's not as robust as we'd like it to be. And the DHEAS was on the lower end of normal. And so for that reason, if we decided to go to surgery, we would recommend definitely steroid coverage, just in case there was any kind of developing secondary adrenal insufficiency due to the tumor.
Thank you so much, Dr. McKenna. Moving on, this is the MRI that the patient got before coming to us on March. I don't know if Dr. Gupta is on the line, and would you like to comment on this?
Yeah, I'm here. I wanted to go ahead and I'll help you out.
Absolutely, sir. So this is a coronal T1. This is the sagittal T1. You can see that mass on the cellular region that you will see better on the post-GAD studies. So here, yeah, we have this coronal cut post-GAD mass heterogeneously enhancing lesion and the cellular region going supracellular, compressing the chiasma, optic chiasm here at this point, and extending laterally towards the cavernous sinus, more on the left side than to the right side. It is not clear to me if it's completely going into the cavernous sinus, but apparently it could be just compressing the middle wall of the cavernous sinus and not entirely going into the cavernous sinus as such. Here you can
see. That's probably more likely.
Okay.
I think it's just pushing on the cavernous dura rather than getting into the cavernous sinus.
Perfect. Thank you, sir. And here we have the same lesion in a sagittal cut. As you can see here, we can appreciate the compression is causing over the optic chiasm, which is something really relevant to see in this kind of patients with this size of tumors. I don't know if Dr. Almeida would like to comment on this further, or shall we proceed?
Yes, I mean, you mentioned, well, the relationship of the tumor with the optic chiasm, the relationship of the tumor with the cavernous sinus on the left side, and I agree with Dr. Gupta and with you as well in terms of the relationship. It's looking more so as pushing rather than invading the cav. But what about the pituitary gland, which is like another very, very important, like, you know, structure here? Would you show us where the pituitary gland likely is positioned there?
Yes, sir. So likely the pituitary gland is pushed towards the right side and on
Why
this
do you think that?
position for the enhancement of the pituitary stalk. I can see that.
Show us the pituitary stalk then.
Go back. Okay.
Yeah. Okay. You see that?
So
Stop. Yeah.
Yes.
Yeah. That white spot right there is the attachment because the tumor reached it all the way up. And then if you follow that attachment, you're going to see that it's a bit more hyperintense on the right side than on the left. But it's indeed, it's difficult. It's not a clear-cut differentiation as you see in some of the cases. But I agree with you. That's the impression that the gland was pushed on the right rather so than on the left. And then with some spray it's like if you were to have some gland thin out right here. And then with the stalk here, of course, then you have to scroll a bit more. And then it's difficult to say for sure, but it's kind of like if the impression was that if you were going to have some gland here. But that was the impression. So in all cases like this, it's in my point of view, I mean, as a surgeon, it would be important to see, of course, the location, the size, the relationship with the cavernous sinus, with its medial wall and with the cavernous sinus itself, and the relationship with the optic chiasm, of course. And in some cases, we're going to have extension into the sphenoid and so on and so forth, which is definitely not this case. So that's it. I think those are the most important points. Dr. Gupta, any additional point?
No, as I said that so sometimes it is hard to tell the residual gland. Most likely the boundary that you were trying to show on this particular image is probably the boundary. Sometimes the gland, normal gland next to the adenoma enhances a little more heterogeneously because it can sort of cause a little bit of a sort of congestion. The adenoma can cause congestion. So the gland may not enhance exactly like what a normal gland does. So at times on post-contrast images is a little bit difficult to tell at times as to what the normal gland is because it sometimes doesn't enhance quite like an homogeneous bright gland. T2s can sometimes be helpful in distinguishing adenomas from the gland, but I suggest that to me, it looks like that this sharp boundary that you're seeing is likely the boundary between the gland and the tumor.
perfect.
As I think, as Dr. JP has also indicated that that's probably where he believes that the transition from tumor to the gland is.
Yeah, thank you so much, Dr. Gupta and Dr. Almeida. So proceeding, at this point, our differential diagnosis would be a pituitary macroadenoma because of the size of the lesion and a craniopharyngioma. The patient at this point was offered for an endoscopic transsphenoidal resection with intraoperative neuronavigation and Doppler ultrasound. He accepted this plan, and as goals for this procedure are to get the patient in and out safe, obtain tissue for diagnosis to the final diagnosis, and obviously to relieve the optic apparatus compression of this mass was causing.
Yeah, I would just add here that, of course, like when you mentioned the three of them, it's kind of like, I would just include that we're going to try to get this tumor completely out, right? It's kind of like, that's in my opinion, it's one of the goals of surgery here. I would define that potentially so as a maximal safe resection, of course, if there is, which is unlikely, like of, attachments to the carotid or so that would be left behind. But one of the goals here is to remove it all completely. But just to add on to those 3 points.
Yes, sir. Thank you. Moving on, as part of his pre-op workup, the patient underwent this ophthalmological evaluation with Dr. Eggenberger. I don't know if Dr. Eggenberger is on the line, would like to comment on this. But basically, what we can see here is that there were no abnormalities during this ophthalmological evaluation, and those both procedures received a good reliability. So
I would say that's right. He looked very consistent on his fields, and both fields look entirely normal.
thank you so much, sir. And also, as part of the pre-op workup, obviously the patient underwent a head CT to evaluate the bony structures. Here we can see the axial CT and the coronal cut, where we can appreciate in a nice manner the sphenoid sinus with all this bony structure. Here we have the anterior client process with some aeration at this point, the optic canal, the foramen rotundum, the Vidian canal, and those beautiful structures that our team from ENT will work on during the surgical procedure. I don't know if someone would like to comment on this.
Maybe Dr. Donaldson, I see that she's here. Dr. Donaldson, any comments about the nasal anatomy of this patient in particular? I don't know if she is available right now. Maybe she had to stop out for a second, but okay. I think that the only thing is that it was a lot of septations in the sphenoid sinus, but quite well pneumatized sinus. You see that both lateral recesses are pneumatized, and that there is actually a very good pneumatization, especially on the right optic strut, as you can see there as well, and a bit in the left. Okay, very good. Maybe let's go ahead, JP.
Yes, thank you, sir. So moving on, we have the video of the surgery. Unfortunately, the part of ENT wasn't recorded until the end, but we have the last drilling of the septations on the sphenoid sinus, as you can see here. You can see here on the right side of the screen, the floor of the cella. It's been drilling on the right side, and on the left side, trying to expose the cell as such.
Yeah, that's still removing the transsphenoidal septations. That's just the most, posterior part of them. And then after that's completed, we come on board, and then you see that if you pause the video there. Okay, that's fine. That's fine. Just stop right there. No. Even there, just stay there. It's fine. So if you look at this here, it's the repetition of the repetition of the repetition. But I think repetition is key. So the first thing we got to do is to have a nice visualization and a clean field. After we got this nice sphenoidotomy that Dr. Donaldson provided us with, then we need to identify the anatomy landmarks in the back wall of the sphenoid sinus, and they're always the same. So that's good. In a well pneumatized sphenoid sinus like this, we can clearly see them. So here's the left optic canal. And then here we got, this is the left lateral optic carotid recess. This is the clinoid segment of the carotid, or the carotid prominence. This is where the proximal dural ring would be running, and this is where the distal dural ring will be running. This is all going to be cavernous sinus here. This is the clival recess. This here is the cella. And this here will be the right optic canal. And then here you got the suction, of course, but the carotid on the right side is right here. The clinoid paraclival ICA will be running in this direction here. So once we identify those landmarks, we're basically going to skeletonize the bone in the cella, remove the cella, and then go to the cavernous sinus, to the anterior wall of the cavernous sinus on the left. Go ahead, JP. So that's it, the bone of the cell is removed. You can see the carotid on the right side there as well. It is really the usual steps. The only thing is on the right side, we don't need to go to the carotid on the right and the left side. We felt that was important because of that extension more to the left. So you see here the left clinoidal ICA, and then the bone is thinned out with the drill, and then you can use a double ball probe. You can use a Carson to basically flip out those small pieces of bone, much so then bite the bone in that area just to avoid cross biting something you don't want to, like a carotid. This is the Doppler. We're using it to map and to identify, the areas of the carotid around the calf sinus. And here you see just removing the last fragment. Once that's controlled, we proceed with hemostasis as usual. And opening the dura, then the round knife just to separate the planes, which is an important maneuver, just so we can try to work in not only in extracapsular fashion, but also to preserve the pituitary gland as a next step. This is a McGalvin knife or feather blade that particularly like to open the dura, and allows us to go into the cavernous sinus more safely when necessary. In this case, you're going to see that the exposure will show us that there was no need to really go into the sinus, but at the sinus. So just completing the exposure, and we get the exposure on the left side. You see here just separating the dura and the gland. And then we can go into the same thing on the right side. This is just removing some tissue so we can send that to pathology. And then Dr. Gentoft and his team will tell us what is up about this tumor. And then here you see this orange yellowish tissue that you saw a glimpse of it on the right corner. That's the normal gland. And that's, of course, the first structure that is important for us to identify as well. We want to keep that in mind. We want to keep that location in mind so we can preserve that gland. So it's one of the first most important steps of the surgery. After that, we go all the way to the cavernous sinus on the left side, to the medial wall of the cavernous sinus on the left side. And then you see here, it's trying to go extracapsular. The important detail is by doing that on the bottom part, there was tissue that was compatible with tumor. Can you stop the video there, JP?
Absolutely.
Just pause. Yeah, right there. So there was tissue here that was coming that we dissected, there was tumor, but then there was this tissue, right? That is the tissue that we're dissecting. And then this tissue here has an appearance in a vascularization that is not, similar to the tumor that we had resected. So this is likely that top part of the gland that was going towards that left side. And this is the part that, well, if this is the top part of the gland here, we're gonna have some diaphragma. And then if we try to dissect that, first thing you're going to have a panhypo, right? If you remove the entire gland. The second thing, you're going to have a CSF leak. So then we had to explore, and then you're going to see that we moved from that left side all the way to the right side, coming from here to inspect this area and to clean from inside out, and then we maximize the resection. So let's continue the video. So you see the medial wall was clean there. Hemostasis. A lot of hemostasis, by the way. That's on me. And then coming from the right, just, stopping and using just so we can have a better view. And then you can see, can you stop the video there just to show the difference between the tumor and the gland? So here you see that there is some yellowish tissue coming from this area. And then there is this red orangish tissue here coming the top. So this here is tumor, and this here is the normal pituitary gland that we have to separate and differentiate so to preserve the pituitary function. Now go ahead, please. So you see, so then we're coming from, right to the left. And then at that point, I'm gonna, objectively transect part of the gland to get all that piece out. And that's fine because the gland is, in this patient, is quite large and big. So you see all of this here is normal gland on the right side. And then you can see the cavernous sinus wall, the medial wall is intact. We don't see, this is the roof of the cavernous sinus. This is the medial wall of the cavernous sinus, and they were intact. Then we proceed with closure with gel phone, bio-designed, and I don't know if there was a mucosa flap there as well. Just bio-design. So I don't know if Dr. Donaldson is here to.
Yeah.
Hi, Angela.
So I think, okay, can you hear me? So
Yes, yes.
I think just a couple things. I think this is one of those collaborative discussions, which I kind of harp on for these meetings. When we think that for better exposure, you need to expose or take the bone off the carotid, then you need to have a discussion about where your other boundaries are. Where are you going to leave bone so that if your reconstruction is more than just a simple inlay of bio design, how are we going to make sure that that's tucked properly if there is a little bit of a leak? So you were talking about that you could see the diaphragm, which we obviously didn't violate, but if you accidentally or unintentionally had a small leak and both carotids are exposed, but only one really needed to be, or was going to make your access easier, you had to leave proper bone, because the key and the most important step in preventing a postoperative CSF leak is that first layer. So you can put multiple layers, but if they are not properly tucked, you're still going to increase your risk of a postoperative leak. So kind of thinking about the strategy of how I'm going to reconstruct prior to opening up the bone is key. You can't just say, what are we going to do at the end when we have a leak and we have no bone to reconstruct to? So preparing, thinking about that in advance will make the postoperative reconstruction and therefore the patient's postoperative outcomes much better when we consider those things as a part of a key element of the surgery.
Absolutely, absolutely. Thank you.
Thank you, Dr. Almeida. Thank you, Dr. Donaldson, for your input. Moving on, we have the post-op imaging of the patient. Here we have a coronal cut on a T1 without contrast, where you can see all these post-surgical changes, and the mass, well, the optic chiasm compression was completely relieved at this point, and no obvious residual was seen on this image.
The coronal T1 is really not useful for this. So let's see the post-op GAD.
Yep. Here we have the coronal T1 and post-GAD. You can see here the pituitary stalk and the normal pituitary
Show us
gland.
the normal gland.
So the normal gland will be right here.
Yeah, it's just your arrow, at least to me, it's a bit off a bit, but it's exactly where you were showing. So this is the stalk, and then you can see the gland coming here and a bit of the gland in the top here. Good. And then the left side, of course, is the surgical cavity.
Yes. Okay. So moving on, we have pathology. I don't know if Dr. Gentov's on the line would like to comment on this.
Yeah, I'm on the line here. If you can see, this looks like a low power view of it, especially on the right-hand side. You have what looks like a very monotonous population of tumor cells. If you could go to the next slide. The tumor was staining positive for PIT1 and prolactin. And so that's consistent with a prolactinoma. For some reason, the slides reformatted a little funny. I don't know if the right slides went through. I'm sorry. This is also showing SF1 staining alpha subunit. So if you go to the next slides. This is a different case. I must have sent the wrong slides.
Yes, I didn't receive your slides, sir. I'm sorry. So I add these slides. So
okay. So anyway, in the case that we had, it was a very monotonous tumor that had positive staining for PIT1 and very positive staining for prolactin without staining for other things. So it was a prolactinoma.
thank you so much, sir.
Do we have the slides for the other case as well? Because I can resend them right now if need be.
I think
I had the ones for the
Yeah.
images on me.
Hey, Dr. Gentoft.
Yes.
You know, the official path report on this gentleman does talk about both elements in the pathology report. PIT1, SF1, generally not overlapping.
Yeah, I'll have to double check. Maybe I have my cases mixed up, because the cases I took pictures of yesterday was just pretty much pure prolactin. So Susan, if you could send me the MRN.
Absolutely.
I was out for the last week, 2 weeks with COVID. So people were assisting with my cases. So I just want to make sure everything's okay.
Great, thank you.
Yep, thanks.
Thank you, Dr. Gentoft, and sorry for the confusion. Moving on, we have here the post-op labs. I don't know if Dr. McKenna would like to comment on this.
Yes. So as you can see, the prolactin came down nicely to 5.7 on post-op day 1. And then the concern about potential for developing secondary adrenal insufficiency, it actually was not the case. The cortisol was very robust at 33. So therefore, the patient did not need to discharge on any kind of steroids. And the sodium remained stable, 139 and 140. Dr. Chang, anything else to add?
No, I think that the pathology, though, is the correct pathology report, because it makes sense with this interesting case of the prolactin being mildly elevated. I have not seen a double adenoma at all, but this is also a rare combination. So I thought that was of interest. And I talked to Dr. Sampson yesterday about that. It's usually growth hormone and ACTH silent or secreting. And typically, you know, I don't think there's any information about the course of these patients, if they do any better or worse. There's no correlation with Chi 67 or invasion in terms of the different types, even when they look at epigenetic patterns. So it's an interesting tumor type, but maybe in the future, with profiling, we'll be able to better guide the course. It's just very rare. It's like less than 1% of these tumors. Anything else, Dr. Sampson?
No, I agree. I just was interested in whether this was like a collision tumor and two things rose up clonally separately. But when, you know, if we will confirm with Dr. Gentoff with the path, but you see these two tumors interspersed with how it looks on the slide. So it'll be very interesting to see. Great case.
Thank you so much, Dr. Sampson, Dr. Chang, and Dr. McKenna. Well, this patient was discharged on post-op day 1, neurologically intact, no DI breakthroughs, no signs of CSF leaks. The only thing he presented was minimal headaches episodes, 3 out of 10, that completely controlled with acetaminophen. So thank you all for being here, and thank you all for your input.
Thanks, JP. While we get Chase getting ready to the second case, I wonder if any questions or any comments from the rest of the team in the audience. And well, I think that if not, then maybe let's proceed with the next case. And then if we have a bit of space, we can have discussions. But I know everybody has a tight timeline today, including myself. So please, let's go ahead. And thanks, JP.